Hey, um, welcome everybody. We'll get started. Um, Dr. Lou and I apparently are at the same location per our Zoom backgrounds. Welcome to this month's DRISS presentation, which will be led by Dr. Yao Lu. Excuse me. Uh, Uh, Dr. Liu is a clinician scientist and a past chair of the American Telemedicine Association Ocular Telehealth Special Interest Group. She has over a decade of experience in telehealth for diabetic eye screening and is a co-author on national guidelines for telehealth use in diabetic retinopathy and glaucoma. She's the principal investigator of the NIH NEI UGI funded iTrust study which is called implementation of teleophthalmology.
Teleophthalmology.
There you go. In rural health systems, which is a multicenter clinical trial to advance telehealth for diabetic eye screening using implementation science. I'm super excited to learn more from your presentation today, and I know we'll have time for questions at the end. So if everybody can just plan for saving your questions until then, that would be great. So yeah, thank you, Dr. Liu.
All right, great. Thanks for the opportunity to present today. We're excited to share with you an update on our teleophthalmology research program, the iTrust study, or implementation of teleophthalmology in rural health systems. Before I get started, I just wanted to point out that for those of you who are attending the National D&I Conference next week in Arlington, Virginia, I'll be chairing a session on a similar topic, evaluating determinants of implementation in multi-site intervention trials on Monday, the 11th at 11 o'clock Eastern. So if you can join us, we'd love to see you there. I have no financial disclosures. We have funding from the NIH as well as several foundations. I'll start by talking about the urgent need to expand ocular telemedicine or telemedicine-based eye care for health equity. What are some of the challenges and opportunities to leverage implementation science in this area, and some of our future directions for effectively increasing health equity. So how did we get interested in this? Well, I actually started working on telemedicine over 10 years ago. And at that time, it was sort of a niche field. People really didn't think it was necessary. It was sort of this extra thing that we did on the side. And no one's ever going to really need to use telemedicine. Well, that changed a lot, obviously, during the pandemic. And so there was a lot more appreciation for how challenging telemedicine would be to implement and how critical it is in a public health emergency. So as a result of some of the consequences of the pandemic, I think we've really benefited from an improved understanding of how critical telemedicine is for expanding our ability to take care of our patients and more equitably than ever before. So what's happened now since the pandemic? Well, as many of you who are in the clinical fields know, we've been experiencing much higher patient volumes. We have fewer staff and clinicians, with nearly 20% of healthcare workers quitting their jobs during the pandemic, and a very significant number who reported intending to leave practice very soon. Many baby boomers are retiring in droves these days, and as you can see for the US population predictions, the population over 65 is going to nearly double over the next few decades, whereas the supply of future clinicians and healthcare workers is staying relatively stable. So how can we possibly meet this increasing demand for eye care, as well as many other parts of healthcare? Older adults have the greatest healthcare utilization. So this is a big problem for all of us providing care, and those of us who will be joining that over age 65 population and will be seeking care. So we really need better ways to provide care to everyone, knowing that we'll have fewer people to do that. So we also have, as a result, an opportunity to advance health equity by increasing access to patient-centered high-quality care and doing so at lower costs than ever before. Furthermore, since the pandemic, many patients now have come to value and become accustomed to having multiple telehealth options. So I think the cat's out of the bag here. Everybody knows that this is the direction that we need to go from a supply standpoint and from a demand standpoint. We're just like all of us can't imagine not being able to order something online and have it delivered to our door. I think in the future, it will be very difficult for patients who expect the ability to be able to obtain care from the comfort of their own home and have that on demand to not be given those opportunities. So what happened? Let's look back at what happened during the pandemic to understand where we need to move to in the future. When the pandemic hit, this is data from April 5th, so just after the WHO declaration of the public health emergency across the globe, we found that in-person visits declined substantially across all fields, and ophthalmology was the hardest hit with a nearly 80% decline in outpatient visits at that time. There was simultaneously a dramatic increase in virtual care, and it was really impressive, the many-fold increase in adoption of telemedicine during that time, which was seen to be essential. Unfortunately, by the end of December 2020, you can see that the use of virtual care declined to nearly 0% of outpatient visits in ophthalmology. And that was really a result of how difficult it is to provide telemedicine-based care in a field that really relies so much on the in-person exam and specialized equipment that is not easily available at home, whereas other fields like behavioral health and endocrinology that provide a lot more counseling, or in the case of endocrinology, counseling after laboratory tests are done, we're much more able to continue to use this type of technology. So what enabled these changes? Well, during the public health emergency, there were major changes in terms of reimbursement, licensure, and technology in terms of allowing non-PHI secure ways of communicating that really dramatically expanded our ability to provide care to our patients in a timely fashion and a safe fashion. Unfortunately, many of those have been rolled back since then. We rapidly provided a lot of different resources to provide virtual eye care, and these are just some of the resources that were made available, including by our American Telemedicine Association. As you know, telehealth encompasses a wide range of different technologies. We typically, during the pandemic, thought a lot about virtual, real-time interactions between healthcare providers and patients. And that was either through video or audio means. You can also provide remote patient monitoring, where patients are wearing some sort of monitoring device, or as simple as counting your steps or counting your heart rate on your smartphone, your smartwatch. Things like using mobile health reminders, texting, and things on your phone with your healthcare team. And in ophthalmology, one of the things that we've been very interested in is hybrid visits or digitally integrated visits, where patients come into the clinic, obtain a lot of tests using specialized equipment in the clinic, and then they get either an asynchronous letter, so by a healthcare provider who's reviewed their information and given them their recommendations, or then followed by some sort of virtual interaction to discuss the results. The most common and well-established form of telehealth in our field is store and forward, which basically means that you take a picture, you store it, and then you forward that image to someone, usually an eye care provider at a distant location, who can review it at another time. So it's much more like radiology in terms of the way that we provide telehealth, although it's not typically thought of in the radiology context. And so one of the other issues that came up during the pandemic was that equity became a big problem, not only due to differences in socioeconomic status and vaccination rates and mistrust, but also access to devices that allowed people to use telehealth. Many of our most vulnerable communities, including underserved communities of color and rural communities, those whose primary language is not English, those with disabilities or impairments in vision and hearing, And, quite frankly, older adults in general really had a limited ability to utilize a lot of the technologies that were really critical to allowing people to reach out to their healthcare team at this time. And you can see in 2018, 40% of Medicare beneficiaries didn't have access to a computer with high-speed internet at home, and about half lacked a smartphone. So this is a very common issue in our patient population. Furthermore, there's a lot of excitement about the use of artificial intelligence and clinical decision support algorithms, but we have to remember that those can also perpetuate the same biases that led to the data that they're based on. So there has to be a very thoughtful way in which we leverage and utilize these technologies in order to advance rather than worsen, advance health equity rather than worsening health disparities. I'd like to focus my talk today on rural eye health disparities for the first part, and we'll talk more about urban communities of color later on. So this is really the rationale for the iTrust study, which I will be describing shortly, don't worry. The main goal of our study is to prevent blindness from diabetes, a disease called diabetic retinopathy, which is actually the leading cause of blindness in working age US adults. And this is a big problem because the prevalence of diabetes is projected to increase by 2 or 3-fold by 2050. So it'll become an even more common problem for our patients. And unfortunately, rural communities have a greater burden of disease and more severe disease and less access to eye care than their urban counterparts. When we looked at how can we solve this problem, we looked at, well, as eye care providers, we only see about half the patients with diabetes that we need to be seeing each year to provide screening to look for diabetic eye disease. And instead, 90% of patients with diabetes actually see their primary care clinician at least once a year. So those patients are getting their labs checked, they're getting refills on their diabetes medications. And so we really need to go where the patients are, which is in the primary care clinic. So how does teleophthalmology work? So in these programs, what we do is when patients are identified by their primary care provider as being due for diabetic eye screening, photos can then be taken in the same building that same day in less than 10 minutes. You don't need any specialized training to take the photos. It's a touch screen. I like to tell people how our technicians, 11-year-old granddaughter at a health fair took all the photos. So if you can use a touch screen, you can pretty much learn how to take high quality images using this type of camera. The images are then sent electronically to eye care providers at another location who can review them at another time. And a report goes back to the patient and primary care provider, usually within a week. And those people who actually need additional in-person care and treatment can then be more rapidly identified. So there's a lot of benefits for patients. It's convenient, it's fast, it's low cost, and you can get people into care much more quickly who have vision-threatening disease. These are just a few of our patients who benefited from our program that we piloted at Mile Bluff Medical Center in rural Boston, Wisconsin. One of them, Larry, described his experience and said that if it wasn't for this program, I would be blind in my right eye by now. And so the camera identified and detected his diabetic eye disease early, and his vision was saved because he was able to rapidly get into treatment. So unfortunately, we look at these programs, they're very complex. They take a lot of resources to set up. And we assume that if we build it, they will come, meaning, once we've invested all of this time and effort and trained staff and purchased these cameras, that, they will, magically improve outcomes. And I will say that there is a lot of evidence. This is an evidence-based intervention. The English National Health Service and the VA health system here in the US have utilized these programs for over 20 years, and their screening rates are over 80%. Nationally here in the US, it's about 50% or lower. And for the first time in 50 years, blindness, the leading cause of blindness among working age adults is no longer diabetes in England as a result of the national rollout of this program, care of the NHS. So we know these programs are incredibly effective. Unfortunately, what happens is we set up these programs, a lot of well-meaning people spend a lot of time and effort doing that, and the cameras just end up gathering dust in a closet. And so our question, well, let me show you the data first. These clinical observations were borne out in this randomized controlled trial that was led by Steve Mansberger several years ago, where they randomized patients in a primary care clinic to either getting telemedicine-based eye care or traditional diabetic eye screening, which involves going to see an eye doctor, getting your eyes dilated at a separate appointment. And what they found was the initial increase was very dramatic, but within 18 months, the screening rates declined dramatically and never exceeded 55%, even after they offered telemedicine to patients in both arms at no cost. So they really struggled, as you can see, even after you overcome some very commonly cited patient barriers, such as cost, that it wasn't enough to really drive the screening rates up as high as we would hope. And so this is where implementation science comes in. I know that as many of you have logged in, you're probably very familiar with implementation science, but I think it's really important to rationalize and justify and define implementation science for a lot of audiences, particularly funding agencies and other groups that may not be as familiar with it. The NIH defines it as the study of methods to promote the adoption and integration of evidence-based practice into routine healthcare and public health settings. And some of the key concepts here are the intervention, which in our case is telemedicine-based eye screening, the context, primary care, the recipient. And I think this is interesting. It's not just the patients, it's actually the healthcare team. They're the ones actually delivering or utilizing teleophthalmology along with the patients. And so we have to be mindful of what their needs are. And then facilitation. And that's something that we've been working on in terms of our program to better integrate this technology into primary care clinics, where we have a coach-based program to better facilitate the integration of this type of technology into the day-to-day workflow of primary care. And so why do we need implementation science? I'm sure many of you have seen this. And so we know that it takes an average of 17 years to translate just a small fraction of clinical research into practice. I think it's really helpful when describing implementation science to people to give a concrete example. And so this study that was led by former CDC Director Rochelle Walensky looked at what affects the clinical outcomes with COVID-19 vaccination. And what they found was that factors related to implementation, like manufacturing delays and lack of adoption or mistrust by patients, contributes more to the success of vaccination programs than the vaccine's efficacy as determined in clinical trials. So, while people are debating about the efficacy of the Moderna versus the BioNTech, these tiny margins, it's actually the implementation that is far more critical to getting the clinical outcome that we desire. So just something to keep in mind. So going back to our study, so how did we get to this point where we're running a multi-center clinical trial? So we started out with our pilot, and this was based on funding from the Wisconsin Partnership Program and a K23 award from the National Eye Institute, where our goal was to simply increase diabetic eye screening rates using this type of technology in rural primary care clinics. And we partnered, as I said earlier, with Mile Bluff Medical Center, which is a rural health clinic located in Juneau County. Now, at the time, this is back in 2015, Juneau County was ranked near the bottom of all counties in the state of Wisconsin based on national health and socioeconomic factors. And what we did was we conducted interviews with patients, clinicians, and administrators to identify what makes it easier or harder to use this technology, and then worked with them, partnered with them to develop and test a program around teleophthalmology to increase its use in rural health clinics or federally qualified health centers. And so what we've learned from our interviews was that there were many barriers to implementation. Those of you who do any research into what makes it hard to do any type of screening, whether it's colonoscopy, mammography, depression screening, and primary care, I think these will all look very familiar to you. The provider has to identify patients who are due for screening. There's often not a reminder for the primary care provider to do that. They also have incomplete records, so they don't know who has had a diabetic eye exam with an eye care provider elsewhere, and so it's very hard for them to know if the patient is actually due or not. Then the The PCP only has about 15 minutes to cover all of this patient's many issues. And they may not have time to place the order or make a referral for the photograph to be taken, and they don't have time to explain it to the patient. Then let's say that we actually got to talk to the patient, we knew that they were due, they agreed to take the photograph. Well, then what happens sometimes is that the patient doesn't understand, why do I need to take this photograph? They might have just left the clinic without having actually gotten the photograph done. So there are just a lot of different reasons that are all tied to this lack of integration into day-to-day clinical practice and the workflows in primary care that we were able to identify. So we worked with staff in the clinics to develop and test some strategies to address these barriers. I'll step back for a moment and just talk about some of the frameworks we used for our study, since frameworks are always very important in D&I. I think that there's never just a single perfect framework that's going to do everything you need for your study. And there's lots of different flavors of frameworks. And just to give you some examples, the actual strategies that the team used to test in the primary care setting, we were able to name and define using the ERIC framework, which is very commonly used. And it just kind of categorizes the different types of strategies so that there's a agreed upon nomenclature that everyone can discuss together. We used an adaptation of the NIH model for our process, and that was as a well-established healthcare process improvement framework developed by Dave Gustafson's group here at UW-Madison. And then we use the REAIM framework for our evaluation, so looking at the actual implementation outcomes. And so, again, looking at the title of our talk, we talk about the iTrust study as being a type 2 effectiveness and implementation hybrid study. And that just simply refers to the fact that we'll be interested in the larger study that we're doing in multicenter clinical trials, looking at both traditional effectiveness outcomes, which is diabetic eye screening, as well as implementation outcomes such as provider adoption and referrals or orders for teleophthalmology. So this is just an example of how we adapted the NIH model for our intervention, which is called EyeSight, or Implementation for Sustained Impact in Teleophthalmology. So basically, you involve a small team of people with very specific roles. You use these very helpful tools that give you basically an operational guidance on what to do with these folks once you get into a group and how they make decisions together. Then you have a specific aim that you're going to target and use existing resources so that you can work as nimbly as possible to do these rapid cycles of PDSA or Plan Do Study Act to see what are the impacts of the changes that you've made on the clinic and looking at the results very quickly. So the change team usually includes about 8 to 10 primary care clinicians, staff, and administrators. These are frontline folks. These are not administrators sitting in their offices who are musing about what might help these poor primary care staff who are, being stretched thin each day. It's actually the people who are taking care of the patients, who are actually taking the photos, who are actually talking with patients about and referring them for teleophthalmology, who make the actual decisions about what are the barriers and what strategies to test. We also use flow charting to look at what are the different steps in the workflow and where are the significant barriers located. I do want to spend a moment talking about the nominal group technique because I think this is a really helpful tool. And so this is a structured facilitation where we go around the room. So everybody on this small group, this change team, is allowed to contribute one idea. And so that we try to get as many voices heard so that the people who are the loudest in the room are not the only ones talking. And you want to have a group, in particular for primary care clinics, that represent a lot of different perspectives. So not just the clinicians, not just the medical assistants, not just the schedulers, not just the IT staff. You want to have all of those people in the same room so that they can talk about how they see the problem from their perspective. So each individual sequentially offers one idea. You keep going around and around till no ideas are offered and people can pass if they don't have another idea. Then you give people a certain number of votes. We usually give people 2 dot stickers, and then they cast their votes to determine and vote on what are the biggest barriers and what are the strategies in a separate session, so that we can have a very clearly defined group decision. Everyone hates going to meetings where everyone's talking and nothing gets decided. And this is a very clear visual way where it's very obvious what the group has decided to support. Plan, do, study, act cycles, I think most people are familiar with. This is commonly used in quality improvement in primary care and other clinical settings to try to look at data, make changes, assess the result of the changes, and then decide whether to continue them, abandon, or adopt them. And so you want to do these in quick succession with some sort of measure that is relatively easy to impact, in our case, teleophthalmology use each month, rather than looking at the screening rate, which is something that is measured over a 1-year period. And so using a bigger measure like that would be very hard to use the PDSA cycles to look at impact. This is just a schematic looking at how do you tailor implementation. So we're basically not dictating to the clinics exactly what to do for their strategies. And so this follows the 9-text model 10 steps. These are some of the implementation strategies that we found were helpful in our prior work. And then we just give examples of how these are applied in our intervention. So as I mentioned, the way that eyesight is structured, it's a coach-facilitated program where we have skilled practice facilitators meet with the clinic, invite volunteers, again, very important, volunteers, hopefully, from the clinic who are interested, excited about using this technology, trying to prevent blindness in their community, and getting together for 2 in-person sessions using the nominal group technique to identify top barriers, and then subsequently, what are the top strategies to overcome those barriers, followed by a monthly sequence of teleconferences to develop and test their ideas to increase screening. What we found in our pilot study is that eyesight increased diabetic eye screening by 36% at Mile Bluff over 2 years. We do have a free online toolkit that's been downloaded over 80 times in every region of the US and internationally that can be used by anyone who is developing a similar program or is just interested in how we did this facilitation. We now are funded by the National Eye Institute to test this program in 10 rural health systems. And so you can see them listed here. We also are working to expand teleophthalmology use, not only in rural settings, but also in urban underserved communities of color. And so this is the main study. You can see we've got 10 sites all over the country that we're working with. Many of these are federally qualified health centers. I just want to acknowledge our incredible team members and co-investigators, many of whom I'm sure are familiar to those on this webinar. We have a fantastic central study team that makes everything go so smoothly, which is always a challenge in a multi-center trial. We have incredible program officers. This is a cooperative agreement, so we work closely with the program officials. Here is our Independent Data and Safety Monitoring Committee, some of whom you'll see at the DNI conference next week. I also wanted to give a shout out, I don't have it in my slide deck here, to our REN coaches who have been fantastic in facilitating this program across our many sites. So what are the actual specific aims of the study? So the first one is an effectiveness aim, which is to test the effectiveness of eyesight versus usual care teleophthalmology for increasing diabetic eye screening rates at each of these primary care clinics. And we have a step wedge pre-post study design to measure the changes up to 48 months. And so this is a really unusual time point because most implementation studies will look at results at 6 or 12 months. That would be a pretty standard time point for your primary outcome. So our primary outcome is actually at 24 months all the way, and we're going to be getting secondary outcomes all the way up to 48 months. And that's because we're really interested in the sustained effectiveness, not just that it was effective for the first 6 months or the first year, but that we were actually able to overcome that initial wave of enthusiasm that usually allows people to be successful early on, but actually to sustain it long term. This is the original schematic of how we designed the study, this being a pragmatic clinical trial. There are a few delays, but this is the overall idea, where you can see it's you have cluster randomization and a step forward where all of the sites get the intervention, but at various time points. In terms of what the intervention arm is getting, they're getting the active coaching portion of the intervention. The second aim is really focused on implementation. So we're really interested in what are the key factors and core implementation components that will distinguish health systems that are able to really increase teleophthalmology use versus those that aren't, after we work with them with the facilitation. And we're using a sequential mixed methods design. We're looking at the quantitative results of the impacts on teleophthalmology use, and then looking at using qualitative data from interviews with clinical personnel to try to explain what caused those differences. Our conceptual model is the I-Paris framework that basically posits that successful implementation of our intervention or innovation will be enabled by the coaches' facilitation to develop various strategies to better integrate this technology into the day-to-day workflow, and that this will allow the recipients of the intervention, which are the primary care staff, to tailor that implementation to their own unique clinical setting or context. So the data analysis is qualitative and basically involves interviews and directed content analysis of that data. This is just an example from Dr. Edward Miek, who is our qualitative configurational comparative methods methodologist, where this is a study that he did with Vera Yakovchenko in the VA. And they looked at many sites at the VA and characterized them as either high sites that had many people go into hepatitis C treatment and those that had very few, and they were able to identify a very small number of combinations of different factors that were able to drive successful implementation. So this is a very powerful method. It's not our typical regression method. It's more of a Boolean method, where you kind of think about it as a recipe where maybe you have certain ingredients but not others. You don't need to have all of the ingredients to be successful. And the question is, which of the ingredients do we need in order to make sure that we can get the outcome that we want? Our final aim is on cost. And we're fortunate to have Dr. Andy Quanbeck helping and his team helping with quantifying implementation costs from a health system perspective, since they're going to be the health system leadership are the ones who determine whether or not to adopt this intervention. And we're looking specifically at health system personnel time tracking using these structured activity logs. In addition, I mentioned earlier that we're interested in expanding now to urban underserved communities of color. So we've been working at outreach community health centers in Milwaukee, which has a large Black or African American population, as well as Access Community Health Centers here in Madison, which has a large Latinx population. And so these are some of our fantastic team members, Christiane and Christian, who have led the initiation of teleophthalmology at these sites, as well as presented their work at many national conferences. And we have several research manuscripts that are in process and some that were recently published. I think in the time we have remaining, I'll move really quickly through this next section, which really gets at what are the factors that influence diabetic eye screening and what we've learned through our interviews with patients and clinical personnel. And I'll start with some of the things that were true across all of our sites. So regardless of whether it was rural or urban communities, there's generally a lack of knowledge regarding eye screening. Very few eye clinics actually accept Medicaid insurance. Many have very few appointments available for the reasons that we talked about at the beginning of my talk. Out-of-pocket costs, especially in low-income populations, make seeing an eye care provider seem far out of reach. Some people also just don't like getting their eyes dilated at the eye care appointment, which we can avoid when we're using telemedicine cameras. Some patients also reported wanting to avoid getting bad news, and there's sort of an element of denial, where if I don't get it checked, then there can't be anything wrong with me. Some of our patients, as you know, they're elderly, they have diabetes, they have a wide variety of physical and mental health issues, that also was a big barrier for them. Time and convenience, having to make a separate appointment to see an eye doctor for traditional eye screening was a challenge, in addition to getting transportation. And then just the day-to-day challenge of having enough food and having safe housing were things that made it hard for people to make this a priority. And things that made it easier to get diabetic eye screening, by far, the biggest motivator was the recommendation from the primary care clinician, understanding what are the benefits of eye screening, getting reminders to get your eyes checked if you have diabetes, the ability to obtain screening in primary care through telemedicine. Patients also appreciated having financial support incentives where the screening was at low cost. Many patients also reported having support, both logistical and emotional support from their family to obtain eye care. Support also came from social workers, patient navigators, and community healthcare workers who helped ensure that patients were getting all of their preventive care. Some of the patients also reported having very high self-efficacy and self-advocacy skills within healthcare, which again is not always common in marginalized communities. And certainly the role of trust was really important. If one trusted the healthcare system and healthcare community, you were much more likely to get care. These are just some of the ways that we thought about the factors, which using the socio-ecological model, thinking about it both at the environmental, social, and individual level. Some of our rural patients described using healthcare very infrequently, that culturally, that was what they were used to, and using the emergency room really as the only time you would seek care because you were having an emergency. And the primary care clinicians also reported that many of their patients hadn't seen a doctor in several decades and end up coming in with a whole variety of very serious medical issues as a result. In our urban Latinx communities, in those patient interviews, a lot of the patients reported wanting their educational materials to be taught using hands-on, image-based and video-based methods rather than a traditional written brochure. And so that was something that's something that we're actually really interested in developing in some of the next phases of our work. Patients also described a preference for Spanish-speaking healthcare providers and being able to better communicate and having a shared cultural understanding. In our Black communities, trust became a big issue, and the legacy of segregation, slavery, and redlining played a big role in why people didn't obtain healthcare just in general. And so we had a lot of very difficult to hear stories about the lived experiences of many people in the community about their fear and a very rational fear of seeking care. People, some of the patients also reported religious faith having an important role in their reason to take care of themselves and to follow the advice of their healthcare providers. But some of our patients also reported that it also contributed to their lack of self-efficacy, where they felt that they were powerless and that they really just deferred what would happen to their health to a higher power. Also, interestingly, some basic clinic policies we found to be problematic for patients. So for those of you who aren't clinical, you may not know that there are often standard policies where if you're more than 15 or 20 minutes late, you will be rescheduled. And this is very problematic for people who don't have easy access to reliable transportation. And this patient in particular described having some very serious mental health issues because 2 of his children had been murdered. and he was not really able to get to the clinic reliably. And he said that the clinic disregarded their policies, and they were willing to see him even when he was late, even though he continually no-showed because they understood that he was struggling emotionally. So in terms of our next steps, we are working now with Cynthia Maldonado on our team to develop and test strategies along with Christiana Folks to work in urban underserved Latinx communities and Black and African American communities to culturally adapt some of our work to address these barriers. So wrapping up here to allow time for questions, I just wanted to let you know that some of the areas that are of significant need in the future for telehealth and health equity include further expansion of policies, reimbursement, education, and implementation knowledge to really ensure that this technology is available to increase access for all of our patients. There is a need for growing evidence to demonstrate the effectiveness of these programs, both in terms of patient outcomes and return on investment to justify the investment by the healthcare systems. There are a lot of exciting emerging technologies with artificial intelligence, new imaging modalities that we can leverage. And I think it's an exciting time to feel that there's a lot of momentum and interest in how can we best actively incorporate telehealth into daily clinical practice to address health equity. So just to kind of conclude here, I wanted to leave you with a few thoughts. It's been said that the absence of disease is not health, and that the opposite of poverty is not wealth. And in our work, we believe that the absence of avoidable blindness is not health, but rather it is justice. So I look forward to continuing to bend the arc of history towards justice with all of you through our efforts to advance health equity and leverage implementation science to do so. And we're just excited to have the opportunity to innovatively apply these telehealth methods to expand high quality care to our most vulnerable populations. So with that, I'd like to thank our incredible team and collaborators and mentors that have been with us through every step of this journey. And I look forward to your questions. Thanks.
Thank you so much for that excellent presentation. I learned a lot and have a few of my own questions, but I'd like to open it up to everybody else. And I see there's a note in the chat already, but if others are, if you have questions, please raise your virtual hand or put them in the chat. I'll proceed with one of my questions. One of the things that I really appreciate about your work whenever I hear you or your collaborators present on it is the salience and prominence of equity in your approach to using implementation science to promote equity. Sorry, I got distracted by the chat. But I'm just curious what you see as sort of the next steps or the next horizons in that way of where you hope your work will go.
Yeah, so thanks for that question. I think this ties in with Christy's question in the chat about trust and how we can overcome these barriers related to trust. And so one of the next things that I alluded to that we're working on is how to culturally adapt patient education. So we know that leveraging primary care provider support is very important, but what happens if you're somebody who doesn't trust the healthcare system and doesn't have a good relationship with a primary care clinician? And so I think there's been a lot of great research during the pandemic, especially looking at the role of trusted messengers. So partnering with community organizations and groups and people who are perhaps outside of the traditional healthcare environment, and working with them to provide that information, whether it's within a cultural organization. We have a lot of different groups like Centro Hispano that have a lot of resources in the community. There are faith-based organizations that people go to regularly that provide a lot of social services, working with community health workers who are well known in the community, and making sure that you have representation, meaning that the materials that we provide, whether it's image or video based, that they are messages in that are being provided by members of the community who look like our patients and are speaking in the language and in the colloquial manner that people would find compelling. I think it's very hard for sometimes if you have a message and it's being conveyed by somebody who you can't really really imagine having a similar perspective to yourself. And so I think having testimonials from patients, from clinicians who are known in the community, I think especially we talked about Spanish-speaking primary care providers as having a very important role. Some of them from Access in particular are very well known in the community. And so having those people providing that information, we're thinking probably using iPads or video-based formats as a short patient education intervention at the time of the primary care visit. It may only be, kind of like a little commercial, a minute or 2 minutes, but I think that can be very effective, especially because there is such low health literacy in the community. People have a much better ability to understand messages that are conveyed through video or images rather than in the written language. So I think there's not been enough attention to that, and there are ways to measure trust and quantify trust. And so we're really interested in doing some studies looking at how we can make effective messaging that also enhances trust.
Great. I have another question, but I don't want to take up all of the question and answer time if others have questions.
I think you should go ahead, Molly. I think
okay.
Can just post in the chat.
Got it. So the given the importance of trust, I'm curious about what you all have learned or what questions you have about an angle on the aspect of trust that I think we sometimes don't think about as much, which is the clinic and clinic workers and clinicians trust or hope or confidence that patients or awareness even of where the sort of root causes for the context in which a lack of trust can be built. And so what have you learned about their perceptions and how those impact that relationship of trust or lack thereof?
Yeah, well, I think trust is a really complicated topic. There are a lot of different ways to look at trust, and people might trust, something in a particular context and not in others. I think from our perspective, the way that we kind of looked at trust, particularly for our Black patient population, was one thing we noticed was that there were people who were very engaged in the health system. They really trusted their healthcare team. They had a really positive relationship there. And those people really trusted the advice of the clinic staff. Then we had another group of people who intermittently use the healthcare system, meaning they may come maybe just once a year, get the medications they need and pretty much not really interact. And in that group, having like reminders and perhaps testimonials that would kind of bring them into healthcare more often seem like a reasonable intervention, as opposed to assuming that they would be having multiple clinical visits in a given year. Then we had a third group that basically almost never utilized healthcare. And so that group would be the group where we'd really have to reach out through, local media, whether that's radio, whether that's, print media, whether that's, YouTube videos and social media. There's so many ways to get in touch with people these days. And having folks from the community that are trusted in the community, that are representative of the people in the community, was really important. We're also planning on doing health fairs, where a lot of people will go to health fairs that are in community organizations, community centers, faith-based organizations that they are already comfortable with going to and providing screening there, because there are some patients that we understand that will not come to the clinic for a wide variety of reasons. And so I think understanding that there's no one way of reaching people, that people are at different points on the spectrum of what they're comfortable with and their level of trust in the healthcare system, I think is important. I think from a patient educational standpoint, I think there's often too much emphasis on data. I think because we are in academics, we are very persuaded by information and data, and we want to know numbers and things like that. And I think in the real world, a lot of people are driven by, and quite frankly, all of us are driven by emotional reasons for why we want to do something. And if you look at advertising, very little advertising is really data driven, right? It's much more creating a sense of urgency, of desire, of sort of relevance that really speaks to something beyond what any sort of number or figure that just provides data could really provide. And so I think the task for all of us in terms of behavioral change is being able to tap into what are the values and what are the things that the messages that are going to get people to act, that aren't always just providing them with a series of numbers. And I think that too often, because we believe in data, we assume other people would find data persuasive. And I think finding that not to be the case, and finding ways of using messaging that provides that emotional appeal, I think is really important. And that's a lot of what goes into motivational interviewing as well, as understanding what are the values of the patient. For example, many of my patients who are glaucoma patients, they have to see an eye doctor many times a year. They have to undergo a lot of testing. They have to use eye drops every day. There's a lot of behavioral aspects of their care that I can't control. But what I can do is I can understand what their situation is, meaning, you can see that they always wear a locket with their grandchild's picture. And you try to find out, like, tell me more about your grandchild. Tell me about what your hopes are for your grandchild. Wouldn't it be great for you to see your grandchild cross the stage when they graduate high school? And, tapping into that is why you're using these eye drops. That's why you're undergoing all this testing. I think it's really important in terms of getting people to do things that we think are obviously important, but may not be obvious to the patient. I'm just going to look at what Christy wrote. So Christy writes, is a scheduled appointment required to get the eye exam camera? Or can it be done as a walk-in? So that's one of the critical strategies that we have recommended, is that patients can have the photograph done as a walk-in. So rather than having them come back for a separate primary care appointment or being scheduled for a specific appointment for the photograph, we try to set up the programs so that if they're in the clinic for any reason, whether that's primary care, whether that's diabetes, education, whether that's lab work, that anybody in the clinic can identify them as being due for screening. We're also really interested in allowing patients to self-schedule, where they can basically just go and get that done. And so, for example, at UW Health, the way that works is that the photos are taken by radiology technicians who are already designed to take walk-ins, because you never know when someone needs a chest x-ray. And so they're already used to having many, many walk-ins on their schedule. And so we are leveraging what's already, the resources that are already available in the clinic, in a way that allows us to make it as maximally convenient for patients to use. So Ryan writes, I'm curious if intervention tailoring at the local level has any steps to manage plan processes that you might worry risk introducing too much variation in effectiveness or fidelity. Do you just aim to interpret that at the end, or do anything prior to their implementation? So the way that we think about fidelity in our study is that the fidelity is what the coaches are delivering. So the coaches are providing a structured framework for process improvement, and the actual strategies that the clinic tests are basically data points for us in terms of understanding what were the core components. So let's say some of the clinics decide that they're really focused on patient education. And let's say that those clinics that really focused a lot of energy on patient education were not as successful as the patients who focused on things like making scheduling as easy as possible, such as creating walk-in options for taking photos or doing the photos on weekends or evenings. Those are the elements that we're really interested in terms of that aim two when we look at implementation. So I think about it differently. So the actual strategies themselves are not the intervention. The intervention is just providing the structure for the clinics to decide on what those tailored strategies are. So Tamara says, a really helpful overview of the approaches. I'm curious to hear more about implementation costs. How has data collection gone? How has this been implemented, accepted? Okay, so this is a huge problem in implementation costing, which is that when you're trying to gather all this data, it creates a huge burden on the people who are having to report what they do. Our coaches have been very good about cataloging, all of their interactions with the clinic. It is very time consuming. Basically, the way we've tried to streamline this is that the coaches in their monthly teleconferences will gather from the clinic champion, usually the clinic manager, what's been done in the past month, who is involved. And we also keep a log of who attended the various meetings and what their roles are. And so there's a tallying based on the Bureau of Labor Statistics as to their average salary and what the cost is to the clinic. But I agree that there's no easy way right now. And there is a little bit of averaging of how much time do you assign to a particular email or phone call that we do. So, but that's definitely a big area of need in implementation science.
Any final thoughts or questions? And if not, thank you so much for a really great and engaging presentation. We will send as a link to a survey, a feedback survey out shortly via email for everyone who attended. Please take time to fill that out. We care about your experience and use that information to plan future DRISS seminars. And thank you so much, Dr. Liu, for your work and its impact in communities across Wisconsin and in Chicago.
Great. Thanks, Molly. I've enjoyed my time here on the terrace with you and everybody else, and look forward to the next. Yeah, a little chilly. Actually, it's pretty warm today. So I hope everybody enjoys their weekend, and thanks again for the opportunity.
Absolutely. Thank you.